Good afternoon, ladies and gentlemen. This is Dr. Chi from Taipei. I'm a radiation oncologist, and today I'm going to give a lecture about our experience of oncotherapy in Taiwan. The topic is Putative Abscopal Effect in 3 patients treated by combined radiotherapy and modulated electrical hyperthermia. Of course, it's a pity that we can't join the conference together in Korea today, but I hope you will see our experience in this 20 minutes presentation. Since 2017, Taiwan had introduced the first oncothermia machine. In our hospital, the place I'm working, Xinguang Hospital, is the first medical center in Taiwan to have this facility. And during the 3-year period, we have seen that mEHT or oncotherm might be an immunotherapy machine. We have done many preclinical experiments and tried to prove this concept. We found out that mEHT had a significant apoptosis rate after treating when comparing with water bath, 37 degrees, 42 degrees, or by conventional hyperthermia machine. We saw that the mEHT had much increased apoptosis rate by either annexin 5 analysis. And this is published at Oncotarget journal. And we found that mEHT and DC cells also induce an anti-tumor immunity. The combined treatment delayed the tumor growth significantly, and it gives a hint that cell therapy and mEHT might be a good companion. And we can see that the yellow arrow, which pointed at the little blue dots, are the lymphocytes, and it was much increased by the mEHT plus DC cell treatment. And in the era of immunotherapy, also we've done some experiments by combining mEHT with the anti-PD-1 or anti-CTLA-4 medications. We have seen that the combined treatment by mEHT with the commercialized IOs, the treatment effect and the response rate are much better than by treatment with medication alone. And also the interferon gamma and PD-L1 was much increased by adding on mEHT with immunotherapy. And this is the data for preclinical, but during the clinical daily practice, we have all the good machines like the mEHT with tomotherapy, the good LINAC machines, but we face the most deadly diseases like the localized HCCs or metastatic esophagus cancer. It's very difficult to treat. And today I'm going to present our experience of combining radiotherapy and mEHT in the 3-year period time. And in those locally advanced or metastatic patients, the goal of treatment is to establish an abscopal effect. It is not a new phrase. It was first described by Dr. R.H. Mau in 1953, and he defined abscopal effect as the effects of radiotherapy at a distance from irradiated volume within the same organism. Well, from 1969 to 2014, despite millions of people treated by radiotherapy, only 46 cases are deemed to be pure abscopal events. In the era of immunotherapy, we found that immune plus radiation had increased the risk of abscopal effect, but still it is scarce. And also some papers have also reported that an autoimmunity mediated anti-tumor immunity existed, which means patients with autoimmune disease may have a better treatment effect. And the analysis today, I'm going to present two goals. The first goal is the post-marketing safety surveillance program of the mEHT as Class 3 medical device in Taiwan. It is a government-acquired analysis to demonstrate the safety of treatment. And the second goal is to report the occurrence of putative, durable abscopal tumor responses with or without autoimmune systemic reactions from the combined treatment of RT and mEHT. The design was a retrospective single-institute case observation case cohort study, and the patient enrollment are from January 2017 to November 2017. And patient must combine radiation and mEHT with or without systemic therapies. And the treatment response were evaluated at the radiation and hyperthermia treatment site. The inclusion criteria for patients, the patient must be older than 20 years old. The cancer status must be inoperable, recurrent disease, or metastatic diseases. And radiation was given 2 to 3.5 gray per fraction, either by definitive treatment, salvage treatment, or palliative treatment for at least of 30 gray. And mEHT was started from 80 watts, gradually increased to 150 watts, was performed weekly and given at least 4 times of treatment. And systemic agents before, during, or after RT and mEHT are allowed. And the two outcomes, the primary endpoint was the treatment-related toxicity. The second endpoint was radiologic response, overall survival, and changes in the neutrophil to lymphocyte ratio, or the N/L ratio. And on the following section, I will present our result of the study. A total of 33 patients with recurrent or metastatic disease were enrolled, and the median age was 59.4. And because it was a retrospective study, the disease entities were quite with a big variety. But the most common diseases are breast cancers, 8 patients, lung cancers, 4 patients, liver cancers or bile duct cancers in 6 patients. And most of the patients combined systemic agents, 31 out of 33 patients, during the treatment of RT and mEHT. And also 21 patients received systemic treatment after the localized therapy. The primary outcome of toxicity, which is quite safe, we have not seen any toxicity more than grade 4. And the most common side effects are grade 1 skin reactions, which was documented in 36% of patients, and 18% of them have grade 2 myelotoxicities, which was mainly the cause of systemic agents like by chemotherapy. The interesting part is we have found 3 unexpected autoimmune responses. 3 patients accounted for 9.1 patients of the whole cohort have shown an abscopal effect. 1 patient had grade 3 autoimmune hepatitis treated by RT and mEHT alone. It's a case of breast cancer. The second case had grade 3 myasthenia gravis treated by RT, mEHT, and immunotherapy. Here's a case of metastatic cholangiocarcinoma. And the third case with grade 2 dermatitis herpetiformis received RT, mEHT, and chemotherapy. She's a case of metastatic urothelial carcinoma. And the response rate of our treatment is quite high. We demonstrated a 60.7% rate of at least partial response. 6% of the 2 patients, or 6.1%, had complete response from our treatment. And interestingly, we found out that tumors larger than 500 cc's had a better treatment response, which is quite counterintuitive with our common practice experience that the smaller tumors should shrink faster than the big tumors. But in our analysis, we found the quite opposite effect. The percentage was 100% and 48 versus 48%, which is smaller than 500 cc's, and 100% all the patients had responses CR or at least PR for our treatment. And the 8 patients included 4 breast cancers, 1 UCC, 1 cholangiocarcinoma cancer, 1 liver cancer, and 1 cervical cancer. And all the 3 abscopal effect patients are included in the GTV larger than 500 cc cohort. And for overall survival, we demonstrated a median overall survival rate of 13.5 months, which is quite good for metastatic disease patients. And in patients who had achieved CR or at least PR, the median survival rate was not reached, and 9.5 months was found in the patients with stable or progressive diseases. For the N/L ratio, we found that 13 patients had a decreased N/L ratio, which is defined by an increased lymphocyte, which should be a good biomarker after immunotherapy or any kind of cancer treatment. We also find that longer overall survival for patients with decreased N/L ratio. It was 11.4 months versus 8.9 months for the 2 groups. And interestingly, the 3 abscopal patients, they had a decreased N/L ratio. And if you still remember the first 2 cases, the liver cancer and the esophagus cancer, they were in the 33 patients and they had very good treatment responses. And the others are some cases which were having good effects. And on the next part, I'll discuss about the 3 cases with autoimmune phenomena with abscopal events. The first one is a 42-year-old female with metastatic left breast cancer. She presented with a big fungated mass, more than 10 centimeters, and palpable bilateral axial lymph nodes, and she had foul smell when she first came to our clinic, and the subtype of breast cancer was triple negative. She refused chemotherapy and surgery, so she was referred to our department. And this was a gross picture, a very big tumor with foul smell, and on the PET scan we saw that besides a big fungating mass, the right axillary also showed a lymph node. So we did palliative RT of 50 grade to 50 fraction to decrease and to palliative her localized symptoms. We treat the left breast only because we think the right axillary lymph node should not cause any serious problem that fast. And radiation therapy was combined with weekly oncothermia treatment. And she started treatment from February, RT to 50 grade combined with weekly oncothermia. And in April, in July, we saw the treatment response was very good. And the most strikingly, we found that the abscopal effect was found at the unirradiated right axillary lymph node. It just disappeared after 7 treatments of oncotherm. But we found she had an elevated GOT and GPT after oncotherm, and we've checked her autoimmune antibodies and found that anti-double-strand antibody was positive. And she was referred to a hepatologist, and an autoimmune hepatitis was diagnosed. And the picture was the trend of her GOT-GPT. We saw an elevation, but decreased after the use of steroids. And in December, she finally agreed for a simple mastectomy. She took her left breast off, but 3 months later, she developed lung metastasis. The patient refused treatment in the upfront and agreed for immunotherapy after 3 months later when the disease grew larger. But after 2 doses of nivolumab, the autoimmune hepatitis flared up again. But interesting, the lung mass just disappeared. We can see that since June, she started immune, but then 1 month later, in July 30th, there was no more cancer left, and she was fine until now. Even last week, she came back to my clinic. And we can see that the trend of her GOT-GPT after immune, it flared up, and we had it controlled by steroids. Now she was also fine. And the second case was metastatic urothelial cancer, 60-year-old male. She received operation, adjuvant radiotherapy, and presented with metastasis 4 months later, which was looked like this, as psoas muscle at lower abdomen and over the liver. We gave palliative RT 40 grade 20 fractions to alleviate her symptoms. We focused at the low abdomen and psoas muscle, combined with weekly oncothermia and 2 doses of low-dose carboplatin and gemcitabine. And since the start of treatment, she had mild fever and pancytopenia. The antiparietal cell antibody was positive, and general skin rash developed 1 week later, and dermatologist diagnosed dermatitis herpetiformis. And 2 months later, the CT scan showed very good palliative effect. And most strikingly, the liver mets just disappeared, which was quite not possible the effect of 2 doses of chemotherapy. The liver mets is gone right now, and the psoas muscle and low abdomen mets just almost shrinked. And she came back also this month, and she was negative of disease for more than 3 years. And the upper 2 parts are the sites to receive radiation. It achieved very good long-term control, and also the unrated liver mets. After the dermatitis event, she had a long-term control. The third case was a cholangiocarcinoma with multiple bone mets. This patient received palliative RT to liver and to bone, and combined with immunotherapy and weekly oncothermia. Since September, but in December, when she is still receiving nivolumab for the 8th cycle, he developed symptoms of ptosis, lethargy, and swallowing difficulty. And then positive acetylcholine receptor antibody diagnosed myasthenia gravis. But we see that the CT scan showed quite good treatment response, and abscopal effect was seen at the L5 spine, which was uniradiated. And the CA99 kept dropping. It just flared up a little while when he had myasthenia gravis, but after controlling of the symptoms, he remained disease-free. And the picture in May showed that the liver disease was still under control. And it was quite exciting for a patient in a metastatic colorectal cancer. It was very, very rarely seen. And what have our treatment achieved? First, we see that there's a very good radiosensitization effect, a 60.7% of local control rate. And we saw that the larger tumor, the more rapid it shrink, which is quite counterintuitive because 100% in more than 500 cc versus just around 50% in lesser tumors. And 8 breast cancer patients had that SPR. And it is because the larger tumors might absorb more energy more effectively and more uniformly, that the energy can be distributed inside. So maybe more apoptosis or more DAMP secretion led to a good or better treatment effect. And the combined radiotherapy dose, we found that the dose we use is mainly 2.53 grade, which is not the case in preclinical data when we use 9 grades or 10 grades. But there's a report in melanoma patients when we combine lesser than 3 grade with ipilimumab, they had better treatment response in the higher doses. We see that on the left is the patient who received less than 3 grade, they had better treatment effect. And we see that the anti-cancer immunity was also elevated. there was an autoimmunity and abscopal effect. And we think that it is because of local treatment by RT-mEHT released tumor antigens, and the dendritic cells might calm by the attraction, and T lymphocytes may be matured inside the lymph nodes, and maybe there's a chance to go to systemic for abscopal response. And this kind of concept was proved in non-small cell lung cancer. The Pacific trial, after treatment of CCRT maintenance durvalumab, resulted in better treatment response over survival in 12 months, 24 months, and it was published at NEJM. And this month, the advanced bladder cancer after treatment with maintenance avelumab also resulting in a better treatment response. The overall survival was longer than without immunotherapy. And this concept is called in situ vaccination. By local treatment, the systemic effect is increased, and there might be a better option or a chance for abscopal event. And this concept was tested by Dr. Golden. He used GM-CSF and radiotherapy in metastatic cancers and reported a 4.9% CR rate. And the long-term abscopal response was shown in our report. When our patient unleashed anti-tumor autoimmunity, we saw the long-term effect. And we also think a fast treatment response is the key of success, which was also reported by Dr. Gozzi. He said that CR or PR within 3 months is mandatory for improvement over survival. The blue line and the green line were CR and PR patients, and they had a longer overall survival time. And we had a chance, give a hypothesis that immunity and autoimmunity is a balancing act. Since long-term immunotherapy are more prone for autoimmune toxicities, but they are neither deep nor durable. But when the patients had autoimmune effect develop, they may have a chance for long-term systemic control, which is deep and durable. And this concept was also proved in the preclinical stage. Self-antigen specific effector T cell, the autoimmune T cells, the cell clones can eradicate the insulinoma tumors. And we can see that the bold line were the tumor and the autoimmune cells. After treatment, the insulinoma was destroyed, and so the blood glucose was elevated, which was shown on the right. And our study gave us a hint, and it was the first reported data that RT plus mEHT may have a long treatment-free period when autoimmune occurs. And our treatment is safe and effective. We have showed a 60.7% PR rate, at least PR rate, a 9.1% abscopal rate, and the larger tumors responded better. The results were published this year in March at the Frontiers Oncology. And the patients we faced are mostly metastatic or locally advanced, but by our modern treatments like by mEHT, by tomotherapy, by our accelerators, or by our other conventional RF8 machine, we may give a chance for the patient to be more healthy and let our treatment be more effective. Dom speramus, as long as we believe there might be a hope. Thank you very much for your patience. Thank you.